kid.
Yeah, you're the one who didn't.
Yeah, with the kick. No, I'm just kidding. I don't know.
If you guys think of any questions or anything about Office Mix, just let me know, okay? Anything that you need me to send to Lynn that, you know, you go home and you start messing with it and for some reason you're having problems, just let me know.
On Office Mix, will you want like the last slide that has like works cited and such?
No, you don't have to tell me the works cited. I know some of the students have done that in the past, but no, you guys will be, you know, putting in like YouTube videos and stuff like that, kind of covering a procedure or maybe explaining it. Somebody on a video might be able to explain it better than you can, or maybe it just kind of takes you through the procedure. Okay, so yeah, you don't have to worry about that. All right, so let's see. Case study. You guys have any questions on that case study for chapter 4, sorry.
Finding some things after
Or performing an emergency cesarean section? Cesarean section?
Anesthesia.
So on number 3 is what you're asking, right? And yeah. Make sure I have, oh, no, I'm looking at the wrong one. I'm like, that doesn't make sense. So during the appendectomy, the surgical technologist should be ready to quickly set up and assist the surgeon with what additional emergency. Well, anytime you're doing a surgical procedure on a pregnant lady, it could happen that they go into labor or they need to deliver. So yeah, you would need to be prepared to do a cesarean section if they started having contractions. Something, there's going to be something that's going to indicate that they need to do a C-section. Okay. Of course, you guys know that by reading that they're going to put off surgery if it's possible. If it's something like appendectomy, they can't. So I know you guys had kind of asked some questions about different age groups. So pediatric patients like Makila was talking about, they all kind of fall into that basically from birth to 18. And those are pediatric patients. They kind of break those down a little bit further by saying neonate, infant, toddler, preschool, school age, and adolescents. But basically all those patients see a pediatrician. So it kind of sounds strange to me that like a 16-year-old would go to a pediatrician, but they can.
I thought MindTap said it was only up to like 12.
Did MindTap say that?
Yeah.
But the book says 18.
Yeah, that's what I was like.
So.
I was kind of like,
Yeah.
because the book says one thing, MindTap says something else.
Yeah.
I got really confused.
Yeah. Well, I don't know that any of the questions on the test ask something that would be confusing like that. But we'll go over the review, because the review basically it goes over every question. The only thing, well, it even tells you the terms that you need to know. Oh, I know what I was going to bring up here. There's probably a few new things that in this chapter that you guys might not be aware of, or like, what in the heck is that? So now whenever you guys do see things that you're like, I don't know what that means, you need to look it up, okay? If you see like it's talking about some type of an illness, look it up and see, because it'll describe what, it's what it is. So just in case you guys didn't look this up, this Trendelenburg position, I know there's a couple questions on that. I'll show you what it is. So Trendelenburg is the typical Trendelenburg. When they say that put the patient in Trendelenburg, that means their head is down. Okay, so that's this one.
Okay.
Okay, head up is considered reverse Trendelenburg. And when you think about it, this position, so Trendelenburg position, if everything's being moved up towards the chest, then that means they're working on usually gynecology procedures. They're working on, so they move everything by putting the patient like that. When they put them the other way, reverse Trendelenburg, everything is basically being moved down. So everything from this area, those are all, everything's being pushed down. So like the uterus and all that isn't in the way. Okay, and they use those, very common. All right. If I miss something that you guys don't understand, please let me know. So some things about pediatric patients is they may want to bring a toy in the OR with them when they come in for a surgical procedure, just kind of that comfort thing. It's kind of nice if you're able to, when they do pediatric patients, to go out and introduce yourself to them, because they get taken into an operating room and all they see is just a bunch of people with masks. So, you know, for a kid, for adults, it's really scary. For kids, it's even more, brings on more anxiety. So if you can go out and say hi to them and tell them you're going to be in their room. Sometimes they might let the parent walk back so far with them. They don't let the parent go in the operating room with them, because then they got to not only take care of the kid, they got to take care of the parent who's like, oh no, don't hurt my baby. So they just don't do that. So it's better for everybody if parents are left out. I know anesthesia is really good with kids, little kids. They'll do things to help relax them. They'll walk them back instead of rolling them back. They put a mask on them and they'll tell them, oh, this is like going to space. You know, they just try to do different things to get their mind off of what's actually going to take place.
Well, we need to know also like the normal heart rate ranges and the respiratory rate.
It doesn't ask, there aren't any questions that ask those. The only one on that table, 4-1, is about the sinuses. It seems like there's a question. Only ethmoid and maxillary sinuses present at birth. Frontal sinuses develop at 7 years, and sphenoid sinuses develop after puberty. Seemed like there was one question about that.
Code for number 41,
I think so.
in which pediatric age group would all the craniofacial sinuses be fully developed?
Yep. Yeah, so basically an adolescent.
In adolescents.
And then there's one about rapid induction. So for kids, page 56. So they don't have to be subject to long induction times. Patients who are 2 years of age or younger are usually held by anesthesia to hold them. they're usually giving younger patients, they're giving them something to relax them and bring them into the OR. Once they kind of put them to sleep, then they'll actually put in an IV because they don't want to, they don't want to have to fight with the kid to get an IV in, because it's hard enough for adults to get an IV. So with kids, they're pretty much already out of it by the time they get their IV. So temperature, under temperature, that's one of the questions. Neonates lack the ability to shiver, okay? They have no subcutaneous fat and so poor thermal insulation. And the means of taking temperature is usually skin. So they'll put like a strip on them to keep, to measure.
MDOR.
I got like which patient population would septic shock be most likely to occur? I have infants and children, and this is neonates and children. So would it just be pediatric or
Infants and children.
infants and children?
Yeah, and let me look at the question.
Number 4.
I'm guessing not adolescent.
Not adolescent.
Yeah, so the way the question's asked, it makes sense. You won't have to think like adolescents or anything like that. Infants and children.
Number 3, about 2 years and younger, is that?
So infants and toddlers, yeah.
And number 6, is that the stuff that's on page 57?
No, I seen that. Number 6, is that the one?
Yeah.
Yeah, on page 58. No, I underlined it. Let me find it real
I have
quick.
development of pseudomembrane enterocolitis, most likely from the overgrowth of Clostridium difficile, because normal bacteria flora gets suppressed.
Yes.
So would that be the same, would that be the same thing for number 7? Is that-
I have
Enterocolitis.
overgrowth Clostridium difficile is most likely responsible for pediatric cases of pseudomembranous enterocolitis following antibiotic therapy.
So that bacteria, C. difficile, that's what it is. It's,
Is that for number 6 too?
number 6 is, let me look at that question.
Because number 7, it looked like it had a fill in the blank.
Yeah.
Yeah, it says overgrowth Clostridium difficile is most likely responsible for pediatric cases of blank following antibiotic therapy. I put
Oh,
pseudomembranous
yes, I see what you
enterocolitis.
mean. Yes,
I got that one.
yes.
I was just wondering about 6.
Okay, let me look at that.
7 is page 58.
So is that
Pseudomembranous, yeah, enterocolitis. And that is on page 58. Right after number 3.
So 6 and 7 are the same answer?
Yeah,
Okay.
and if you were looking at the test ahead, you could kind of almost answer 6. What's the number 1 cause of death in children? 1 to 15 accidents. Yep. Yep. Let's see. Patient undergoing bariatric surgery may require extra time for general anesthetic. Why? Reversal. Why?
Because it's
Mhm. So it kind of just settles in there. Same with patient, obese patients that take any kind of drug. It still kind of lingers in their adipose tissue.
which one was that?
Number 9.
Would you do examples too, like what classification of antibiotics is contradicted for use in neonates due to increased incidence of maybe herniated pictures? I have sulfamides. But
Yes.
do we need another example, like maybe some examples as to like Bactrim or Cipra?
No. Mm-mm. So some of the things they're gonna, that make dealing with pediatric patients maybe a little more difficult is they need to, first of all, with every patient, they need an airway, right? So they need to intubate the child immediately. If their breathing continues to be difficult, they might get a pneumothorax. They might be more likely to hyperventilate. It's a common response to kids with injury. And I know that's one of the questions. I know the questions will kind of go from here to over here, so I'm just kind of going through the chapter. But if there's anything you guys have questions on, let me know.
Number 10. That's just children. But it says age group, right?
Yeah, it's just children. So yeah, 11 is basically pediatrics. So what organ is responsible for failure for insulin to produce?
Pancreas.
Pancreas.
So it says what the chemical and physiological classification would just be that it's an endocrine hormone that aids in digestion with breaking down sugars and carbohydrates.
Yeah.
Okay.
Yeah, and it's a hormone. So trauma during birth, what can happen?
The soldiers
Dystocia, yeah. Yeah, so, you know, they're on page 58 under trauma during birth. And I know it's one of the questions, yeah.
Question number 20.
So it's a clavicle fracture. And results in vaginal delivery, not a C-section, right? Why?
Because it will get stuck on the mother's pubic bone or the opening of the birth canal.
Yep.
Because the shoulders are too wide.
Mm-hmm.
So the cause is the shoulders are stuck because they're too wide.
Mm-hmm. Yep. So here they are struggling to get that poor baby out, and they end up breaking the clavicle. Birth trauma can injure the sternocleidomastoid muscle, which leads to a formation of a hematoma and torticollis. What's that?
Contracted state of the muscle.
And that's one of those matching.
I think that was on terms to know.
Yep.
59.
Yeah.
So how many pounds does a person that is considered morbidly obese need to be over?
100.
Yep. So some things they're going to come in with could be an enlargement of the heart, coronary artery disease, high blood pressure, varicose veins, pulmonary function complications, liver and gallbladder disease, osteoarthritis, diabetes, pituitary abnormalities, arterial sclerosis, dysfunctional uterine bleeding. So those are all things that obese patients, morbidly obese patients, could also have going on with them. Number 5?
Yeah, what's the severity indicator for trauma?
exploratory laparotomy.
Yeah, and I did find that, and I forgot to write down that page number. Let's see if I can here. Thinking it might be under trauma. Let's look. I know I seen it. We'll come across it. Kind of just going over these sections, we'll come across it because I know I seen it in here.
It's gonna be exploratory laparotomy.
Oh,
Yeah.
it's on 60.
Yeah, and I know in the book it just says laparotomy, right?
It says exploratory.
Is it?
Yeah.
Yep, complications of the gastric surgery.
Okay. So when we deal with obese patients, we need to keep in mind that they're coming into the operating room. They already are aware of how they look. So we need to be mindful and respect all patients, but of course obese patients too. Make sure that they're kept covered. And we don't usually transport patients, but if you're helping transport with all patients, make sure that they're covered. Just think about how you would feel if you were in their situation. So you want to, respect their privacy as much as possible.
17 there or on that page. And that we,
Yeah. So what is something that they could get?
Gallstones.
Yep. Yeah. Yeah. So it is somewhat common. Anymore, I mean, to me, I think I've told you guys, it's amazing that anybody has a gallbladder. Gallbladders, tonsils. Those are really common, very common. And they used to be just more the obese patients, but now I think more because people are eating out a lot more. And so the food that people are eating are causing them to get stones. So you'll see teenagers, you'll see, younger people when you never used to see that before, coming in to have their gallbladder taken out. And what do I call that? What kind of procedure?
Full cysts.
What's that one that I told you guys about that they do so much? A lap what?
Laparoscopy or
Lap chole.
Oh.
Yeah. So when you guys see that scheduled on the board, it says lap chole, you will be like, what the heck is that? That's what it is. A laparoscopic cholecystectomy. Okay. It might be necessary for them to do a venous cut down on obese patients because they're not able to get an IV started like they would on a normal person. Like, for us, usually our veins are pretty easy to find, but on thicker patients, it's tough. And of course they have a shorter neck usually, so it's harder to intubate them. So those are just some of the things.
The venous cut down, is that just exposing a vein?
Mm-hmm. Yep. So for just a normal IV, they might actually have to go in and find the vein because they can't.
Let's see.
Let's see. Yep. Anesthesia recovery time is going to be usually longer because it's going to take them longer to wake up from anesthesia because it kind of stays in their adipose tissue. They will ask for extra personnel when moving larger patients, and it might be necessary for them to bring together 2 operating room tables for a large patient because they might not fit on one. You guys have seen how big the OR tables are in the lab. So for somebody, you know, that's 500, 600 pounds. And I know those tables can hold, I think 1,000, 1,500 pounds. So they can hold them. It's just that they don't fit. So I think there's only one time that I've seen where they put 2 OR tables together, because most of the time larger patients will be sent to a hospital where they can accommodate. They've got larger beds for them. Anytime that they're positioning patients, they're going to look out to make sure that nothing is rubbing while the patient's asleep. When we go to sleep and we become uncomfortable, we move. But when a patient is under anesthesia, they can't move. So we're responsible to make sure that everything is padded. And there was one procedure that I was in. A gentleman came in. He had been extremely intoxicated and had fallen asleep on his arm. And the way he fell asleep, his arm fell asleep. And so when something falls asleep on us, we wake up, you know, we move it. He didn't wake up. And his arm, it was like it had exploded. It was crazy. I'd never seen anything like it. He almost lost that arm. It was very, very close. I know he came back from multiple surgeries because of that. But his flow of blood was restricted for who knows. He had been out, you know, because he had passed out in his vehicle, I think it was, and had been passed out for 12 hours or so, you know, a long time. So when they found him, that arm was bad. So it's amazing. So we're responsible to make sure that we have the patient position. And while we're usually scrubbed in and setting up our case, we're not going to help with that. But if you notice something isn't padded right, or if something's doesn't look like it's positioned right, if you think about, if I were asleep and I went to sleep that way with your neck like this or something, how am I going to wake up feeling? And so you'll tell anesthesia, you'll tell the circulator, make sure that you straighten this up or pad this, because, you know, we need to look out for them. And I know sometimes when they're in all these different positions, their neck will kind of go like that. So you have to tell them, and they'll put it in something and tape it, you know, so it stays in place. People a lot of times will talk about they wake up from surgery, they've had surgery on their abdomen, and they wake up and they say, I don't know why, but my arm hurts so bad, or my leg, you know, and they don't understand. Well, it's because of the way it was positioned maybe, and then also when we're doing surgery, we might tend to kind of lean on them. So we might be leaning on their arm, you know, and then they wake up and they feel that. So you kind of you really need to be mindful of that don't rest your hands on the patient, because when they wake up, they're going to feel that. And so they're going to be sore from you resting on them. And you guys are going to see things. You'll see surgeons who put their arm on the patient's head or something, you know, while they're doing something, and you think, wow, that poor patient, you know. If you're really uncomfortable with the way that you feel the patient's being treated, you need to bring it to somebody's attention. But you'll know when it's okay or a good time to talk about that. Because if you tell the surgeon, are you putting your arm, are you resting on their head? Anesthesia will usually remind them, that's their head, don't put your hand there. You know, because if you accidentally, because again, you know, they're completely covered and you just think of what they're working on. So anesthesia will say, hey, you've got your hand on their mouth, you know, something.
This is kind of off topic, but how common is it for people to wake up during a procedure, like wake up to the anesthesia?
No.
Never seen
No. Every now and then patients will start moving. They're like kind of fighting, you feel like.
Yeah.
Anesthesia is really monitoring all that, and the surgeon will get upset until anesthesia, you know, make sure and give them some more. And so, yeah, anesthesia.
You never had to like restrain someone?
No, No, they have never, as far as under anesthesia, no. When they are starting to wake up after the procedure, yeah. I've had to actually get on top of the patient because they were like almost coming off the bed. And that happens, you know, because the patients, they say most people will wake up the way they went to sleep. So if they go to sleep struggling, fighting, then they're going to wake up struggling and fighting. And I don't know if you guys have ever had anesthesia, but it's like it was 1 second. You know, you feel like, I just closed my eyes.
Yeah, they
That
told me
works
to,
for mine.
yeah, they said to count down from 10 backwards. I'm like, I don't think I made it to 7.
Mm-mm. No, to me, it's anesthesia is amazing to watch somebody go from looking completely wide awake to being out. And it's just in a matter of seconds. Yep, so it's amazing. Okay. We talked about the question about diabetes. It is a disorder of what system?
Endocrine system.
Yep. And it affects the production of insulin, and that's affected where? Yes. And then insulin is a hormone, and it helps in breaking down sugars and carbohydrates. Some of the complications associated with diabetes, and diabetes is very common in this area. You guys might know that. So infection, dehydration, poor circulation, hypertension, delayed wound healing, infection, neuropathy, control of postoperative blood glucose level, neuropathic musculoskeletal disease, neurogenic bladder, so they might get UTIs, retinopathy, coronary artery disease, thrombophlebitis, tachycardia, and peripheral edema. So the patients come in, and so it's extremely important. It's always important. Every single patient you treat the same, but it's, you know, you really have to think about these types of patients, because if we have something that's not sterile on our field, we could cause further problems for that patient, because they're going to have a harder time healing anyway, as it is.
So number 45, vomiting and preoperative narcotics and predisposition to diabetes fluid neurological imbalances result in Okay.
Yeah, it's right there on page 61, that second bullet. So pregnant patients, like I said, most of the times they're going to try, if possible, to delay any surgical procedures on pregnant patients. But if they need an appendectomy, they're gonna have one. So when is it best to perform surgical procedures?
Second trimester.
Why not the third?
Because the uterus is enlarged, and then anatomical landmarks are harder to distinguish, as well as organs have been discussed. Abdominal organs too.
That's right. Of course, they're going to do everything when they have a patient has a cesarean section. They're going to do everything they can to. And what kind of anesthesia are they going to give them? I don't know if it really covers it in here, but normally, if possible, spinal for C-section. Yeah. Yeah. So.
When you say spinal, is that like nerve block type stuff?
Yeah. So spinal is basically blocking, and it blocks everything usually from here down, and usually they can't feel their legs.
Is that just like the epidural?
Yeah, it's like an epidural. Yeah. So they'll bring the patient in the room and put in a spinal, and they're ready to go. If they have an epidural, then they're good. So anesthesia, the 3 important items to remember are the increase in preterm labor, fetal death, and low birth weight. So the anesthetic agents cross the placental barrier and enter the fetal circulation. And of course, the liver is not developed, and so it slowly metabolizes narcotics and tranquilizers. So those poor babies are going to be born pretty sleepy. So yeah, they're going to use short-acting drugs. So some things that are really important for us to remember, especially when we get called in for a C-section that's urgent, is that we don't want to compromise our sterile technique, but we need to hurry. So usually when you get called in, you go set up. Sometimes nurses on that floor will go in and start opening things for you before you even get there, because you want to walk in and start. So once a baby's out, then everything kind of slows down, and it only takes about 5 minutes maybe from the time they make an incision for that baby to come out. So it's quick, and then like I said, everything kind of slows down. It's like, whew, okay, now we can finally relax a little bit here, and then you have time to do all those counts and everything else. What might we have to aid the surgeon doing?
C-section?
Mm-hmm.
Oh,
Instrumentation, supplies, and equipment immediately available.
Yes. And then also palpitating the uterus to detect contraction. So that may not necessarily be during a C-section.
did you say that one was surgical?
It's on page 63, the second bullet. Well, those bullets there talk about that.
Would it also be raise the temperature in the room to prevent maternal hypothermia?
Yeah, and usually that's another room that they're going to try to warm up a little bit for the baby, because they don't, well, and of course they put them in their little microwave things. Incubators.
So which national agencies have regulations and protocols for healthcare workers who may be exposed to infectious diseases in their work environment? Is that going to be OSHA and the CDC?
And there's one more. Yep. So this is going to be one of those where it's important that they do Trendelenburg, right? What's it going to help with?
It's going to help with relieve pressure on the vena cava and the aorta.
Yep.
Abdominal aorta. Baby vein return.
And they do that pretty much every single time. They usually get a blanket and roll it up and stick it on the right side. I think that was what it says. Yeah, right side, and then they tilt them to the left. Blood loss. Anesthesia is always going to ask about blood loss. So will the surgeon. But for C-sections, there seems like there's a lot of blood loss, but there's just a lot of everything in there. So that's kind of one of the messier procedures. A lot of times people think surgery, they're messy, but not usually. C-sections and orthopedic cases are messy. So they have boots that you can put on over your shoes. Orthopedics are messy because they use so much irrigation. It's like you're swimming and irrigation in the OR with them.
Oh, wow.
Yeah, they use lots of
I would even do
irrigation.
a C-section, but orthopedics.
Yeah, yeah. Yep, and it's not usually a lot of blood with orthopedics. They talk about a Doppler. I can't really remember ever really using a Doppler to check the fetal heart rate. They're usually monitoring that fetal heart rate all the time before that mother ever goes back. So who are the patients that are going to be immunocompromised patients? Compromised, sorry.
AIDS.
Hmm?
But the one with multiple sclerosis and
The old, the very young.
Yep. So the old and the very young already kind of their immune system hasn't really developed for babies, and then old people, their older people are starting to break down. Things are starting to break down, so they're more compromised. And then of course people with AIDS or autoimmune diseases.
Mhm.
So MS, lupus, rheumatoid arthritis, people who are recipients of organs, transplants.
And people that are taking agents to combat cancer.
Yes. Yeah. So HIV and AIDS are usually an opportunistic disease. Seems like that's a question.
I'm thinking someone might tap on it, like,
Oh,
used to
maybe.
be the only thought certain people were, but it's actually not.
I missed that one.
That one was on the mind tap.
So, of course, if a patient comes in the OR and they have AIDS or HIV, you are probably going to be a little concerned, but you need to treat all patients like they have that. You know, of course, they're people, and we don't know, even though when AIDS and HIV first came out, they said it was prominently men who are homosexual, but more and more, you know, it's not just men. And I think people are a lot more educated on it than they were at first, for sure. So we just treat them with respect like we would anybody else. Do we take special precautions? We take special precautions with everybody. You know, I think if you think too much about, oh my gosh, this patient has this, you're more likely to do something that's going to cause problems than if you just treat everybody the same. Will they let you know? Probably they're going to let you know. They're going to let you know if they know that the patient has anything. They'll usually, it'll be kind of one of those things when they do that timeout that they talk about. Okay.
so number 33 is that.
Yes. Kaposi sarcoma. Severe, which is a severe psoriasis rash of the body. Does everybody who has that have AIDS or HIV? I don't think so.
So 47, what kind of atmosphere might be deficiency virus group?
So maybe an over dramatization of exposure. You know, you might be overly concerned that, oh my God, I'm going to be, you know, I could get AIDS by touching this patient. You might ask not to be in that room because you're concerned about what if. But
You're working in a health place. So you
Right.
have to-
Right. Yeah, you just can't.
Isn't it only one?
Bloodborne. Yeah, of course, we handle blades and needles that are in contact with that patient's blood. And being stuck with a needle or a blade are pretty common. It happens, probably happens to everybody at least once. One of my students from the last class, I think she got poked 3 or 4 times while she was in clinical. She was about ready to lose it. Yeah. She thought something was wrong with her, and I just told her, I said, I think you're just worrying too much about it. You know, because if you're so stressed out that you're going to get poked, then it's going to be a problem. If you just go in and figure you're going to be okay and nothing's going to happen, then I don't think you worry about it too much. We're going to teach you how to hand things off and get things back the safest way possible. But it happens, so.
What about 48?
So a common surgical procedure on page 64, diagnostic biopsies. So of course, a patient with AIDS is going to have things that are happening to them where they are, you know, there's things that can be treated. AIDS cannot be, there's no cure for it. So they're not going to come in to have surgery to get rid of AIDS because there is no cure. But they'll do biopsies to see, you know, what's going on with this, what's going on with that.
What page is it?
64.
So it must be the diagnostic labs.
Mm-hmm. So yeah, under common surgical procedures.
What question was that?
48. Is question 49 going back to HIV and AIDS? Or is that something? I thought it would be the blind or deaf.
It is physical conditions. So on, let's see here, number
49.
49. So patients with severe arthritis or contractures or tremors. I know I found that. I'm looking.
Page 65.
Is that where you found it?
Physical
Oh, yeah.
challenges such as the absence of an extremity or severe arthritis, contractures, deformities, paralysis, tremors, and stiffness.
Yeah. So let's see. So yeah, dealing with patients who are physically challenged or have sensory impairments. So every now and then we're going to deal with patients like Down syndrome patients. You know, there's going to be some things about them that we need to think about. Their cognitive abilities are not going to be quite the same as ours. Some of them are, you know, pretty smart. But there's things that they have that will be different. You know, they can be a 40-year-old and yet they display some behaviors like a child. So they might be clingy. They want affection. And that's how you build trust with them, is by them knowing, you know, that you care. Some of the things that anesthesia is going to have to think about is they have a flat nasal bridge, a short neck, so it makes it harder to intubate.
It also says muscle hypotonia and joint laxity.
Mm-hmm. Yep. What kind of a patient would need an interpreter?
A deaf.
Yes. And what about if they were blind?
They would need to be given like verbal commands and maybe as well as assistance in doing the commands and help them feel more at ease by describing the room they're going to be in, maybe describing the people who are gonna be there and them introducing themselves.
Yeah, because I mean, it would be really scary to go into an operating room and not know your surroundings. Because blind people, they really depend on their hands to feel things and to know where they're at. So it would be helpful to tell them what we're doing. If they can hear us, as long as they're awake, let them know what's going on. You're clinking around back there with your instruments. Tell them, say, I'm just setting up my table with all these instruments, things like that. Because they'd be like, what's going on?
Freak out, and then you have to calm them down.
Yeah, and I haven't had a blind patient, so I don't know. But, I know that would be something you would need to keep in mind.
I also seem like to take out contacts, otherwise there could be cornea damage.
Yeah, so I'm sure you guys know, like whenever a patient goes into the operating room, they can't have dentures or contacts, no jewelry, and things like that. So some patients are, they're like, there's no way I'm going anywhere without my teeth. So they'll let them wear their teeth until they go back into the operating room, and then they'll ask them to take them out. And then, of course, give them back to them or put them in just before they wake up.
That's
Yeah.
what it says of eyeglasses as well.
Yeah, eyeglasses too. For people who are really bad, who cannot see without their glasses, it's just like being blind. So they will let them keep their glasses. They like to not take personal belongings from patients back to the OR with them, but with things like that, it's more of a anxiety thing. So to help lessen their anxiety, they allow them to take them back with them.
Is that like the children and their toys?
Yep. Yeah. And of course, once the child is asleep, we'll move the toy that they've taken and put it someplace where it doesn't get dirty. Isolation patients. Sometimes the hospital tends to go a little overboard on patients with, let's see, what's a common one? Oh, I can't think of it. But let's say they think a patient has TB. They're going to be extremely careful with that patient. They want to make sure that nobody comes in contact with that patient until they know. If that patient needs surgery, they're going to isolate them when they take them down to the OR. They're going to put them in a separate room where they won't have, any contact with any other patients. What kind of a mask might we need to wear? It was, yeah. And those are the most uncomfortable masks ever made. They're horrible because they're really, really super tight. I don't know if you guys ever had to put one on for anything. They're kind of hard and they're tight. Usually what they do is they have you fitted for one. So, because I think they come in like a variety of sizes. So, you might wear small. And so every year they have you go through that. But, when at all possible, they're not going to bring a patient that they think might have TB to the OR. Geriatric patients dealing with, so what age group are they? Yep. So usually over 65 years old. Anymore, people that are 60, 70 years old, they look pretty good. Used to be that, when somebody was 50 or 60, they were old. But now people have, they're a lot. It's kind of crazy because some people are a lot healthier and some of the younger people are not healthy. But it does say that 80% of geriatric patients present with one or more comorbid conditions when coming into the surgical environment. So they got all other things already going on. And we talked about dealing with dentures. Hearing aids too is important. If they wear hearing aids, they're gonna want to let them wear them until they absolutely need to take them out because they want the patient to know what they're doing to them. It just gives them a little more sense of security by being able to hear what's going on. And then we have our substance abuse patients. And usually substance abuse patients are going to come back with, they already have some coexisting psychiatric illnesses. So if you have a patient that comes back that abuses substances, they might be one of those that go to sleep and they're fighting. And then when they wake up, they're fighting. And it's because they've got other things that are going on. So it would be beneficial to have a counselor or social worker provide assistance to the team and to the patient too, to kind of let them know what's going to be happening when they go back into the operating room. I have never seen a counselor go into the operating room with the patient. Inmates with somebody from the jail, yeah. Did you
Required.
ever transport?
You're required to go in with them. Even had to fight a kind of battle with a nurse. Well, you're not allowed in here. It's like, he's in cuffs. He's one of our high security. I am required to be in there.
Yeah.
So that would be number 29, right? With special considerations or arrangements like these need to be made for a patient with substance abuse issues to benefit the patient or staff most highly involved in the presence of a counselor or social worker.
Yep.
Have they ever needed like maybe more drugs to put them under and such, because some of them might have substance abuse or like
Such
the
Tolerance, yeah. Yeah, and it's kind of amazing how that tolerance thing works too.
Yeah, my aunt, she can't even take, well, she was younger, she used medications, and now I think it's, she has to have, what is it? It wasn't iron, it was like morphine.
Uh-huh.
I think she has to have like small dosages because now she has to absolutely have it.
To help control pain.
Mhm.
Yeah.
And I think she's immune to most kind
Yeah. That was what I was trying to think of. MRSA.
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 is bad.
Well, and they talk about MRSA, and so like isolation patients, that's one of the ones that it's pretty common. But I know like the surgeons that I've worked with said, they are so careful about the way they treat MRSA patients. Like they put on, anybody who's transporting them puts on a gown, gloves, which you wear gloves to transport any patient, but all this stuff. And just the way that they're treated like that, not that they're treated badly, but the special precautions. And one of the surgeons I worked with said, all you have to do is go to Walmart. All those patients with MRSA are going to Walmart, Safeway. They're going to these places. And it's more of a, if you're immunocompromised, then there's a chance you might get it.
So I didn't read all of that part yet, but MRSA can say somebody has it in their urine tract, and if they pee on the toilet and then you go and sit and you notice you sit in a wet spot, can you get it that way or no?
Of what?
Of the MRSA.
MRSA? No, I don't think so.
Okay.
No. And do you know what MRSA is?
It's isn't it like an antibiotic?
A resistance. Yeah, so
It's extremely antibiotic resistant.
it is. Yeah, so patients, for a time, every time you got sick, you went to the doctor and they gave you antibiotics, penicillin. That people did that for a long time. And so people have built up a resistance where if you get sick, it doesn't help you anymore. So when these patients come into the hospital, they have to treat them with different types of things because antibiotics and penicillin and all that don't work for them.
What do you use for MRSA? It's the vancomycin.
Yeah. Yeah, I think so. And then there's also that too. there's also people who are resistant to that. Yeah, so the MLT program that they used to have here at San Juan College, they were doing a study on honey, and they were finding that some of the properties in honey could actually help with MRSA patients. I don't know whatever happened with that, because the lady who did the MLT program, she retired, and that program has kind of gone away. So I'm not sure. It seemed they had it called the Honey Project, and they were trying to find something to help, because we have such a large population with MRSA. But really, if we're just healthy, and every time you go to Walmart and Safeway and everywhere else that you go, wash your hands, you're going to be fine. Trauma patients.
So 36 would that just be trauma patients?
Yep, trauma victims. So the golden hour refers to the trauma victims. And what does that mean, the golden hour?
Working within 60 minutes, so that way, within, treating them within the first 60 minutes or within the first hour.
Yep.
Determine the outcome.
Yeah, so patients that are, people that are treated quickly have, of course, more likely chance to survive. A level 1 trauma center, it can meet all the needs required for treating trauma patients. So they have personnel and equipment that's on 24-hour basis. And I can't remember what San Juan Regional is. I'm thinking 2, but I think they might be 3. Even though I feel like they treat almost everything.
What's Mercy?
I would think it's either a 2 or a 3.
2 or 3.
Mm-hmm.
So Albuquerque would have the
Albuquerque.
level 1.
Yeah. So it says San Juan Regional is a level 3, which to me is kind of surprising.
We're down on the list, huh?
You guys
Yeah.
don't have a burn center or what?
Maybe so. What's been amazing to me is that up until just recently, we had neurosurgeons, who could do brain, but other places like Las Cruces, they didn't even have neurosurgeons. So to me, it was like, wow, we have them and those places don't. Because I think they have 3 right now here. I don't know, you guys could ask Dell about neurosurgeons, because we used to have really good neurosurgeons here. And I'm not saying the ones that are here now aren't, but they're not here permanently. They're like, they just come here like, next week I'll be there. So they're not here 24/7. They're kind of like on their schedule. It's like, oh, we'll be there during this week. So anytime anybody has a brain injury, they have to send them someplace else. Kinematics, what is that?
Mechanisms of injury.
In a trauma patient,
Trauma mechanics.
velocity of the injury force, flexibility of the tissue, and shape.
Injury mechanics.
So 37 is what?
Blunt trauma.
How about 38?
Blunt force trauma.
Blunt, yep.
What?
38.
Projectile.
Forward injury.
38 is penetrating.
Penetrating.
Penetrating. So it can be a knife also.
Penetrating, bullet, low velocity, high velocity. Those are penetrating.
I noticed in my tap, it said the
GSW.
GSW, and I haven't seen the book for
Oh,
that.
gunshot
I
wound.
looked everywhere,
Me
so I was
too.
just
I
like
missed that
guessing.
one. I
What
put
is it?
gunshot wound.
Yeah,
I put gunshot wound, I got it right. I was like, I took a guess. Like, took a guess. I was like, hey, you got it right.
Yeah. I looked forever.
Yeah, and I don't think
I
it says
couldn't find
anything
it
here
anywhere.
about that, huh?
No.
I lived in a whole chapter.
What did you
It's
tell
talked
you?
about gunshot wounds in there being penetrating, but. and
Yeah.
Yeah.
And preservation of evidence, but it didn't have that specific cheap.
Yeah, yeah. Yeah, and then we talked the other day about preserving evidence and how they might need to wrap the hands to preserve evidence. I know that's one of the questions in here.
I also seen how you gotta cut the fabric around where the wound was.
Yeah.
And you can't use metal to take the bullet out, because scratching can mess with it.
Yes. Yep. So what are we going to use to take the bullet out then? If we can't use metal, all we have is metal instruments.
So you have instruments that are
Like rubber.
bits and something.
You like suction it out?
I don't know.
Just use your finger.
Use your fingers.
Yeah. Maybe just use your fingers.
I'm thinking you can
Put
get fingers, you might
fingerprints on
mess
there.
with them.
Yeah, it's all right. You're cutting it open, them open anyway to get to it because gunshot wound, when it happens, it just shatters everything around it. So it's not clean. There was a guy that did a presentation. I can't even remember where, if it was at one of the conferences, but he talked about how gunshot wounds, how they really react. It's amazing.
Sometimes the impact of the bullet, not the bullet wound, but like the surrounding tissue is more messed up than the bullet wound.
Yeah, just like motor vehicle accidents, when patients come in, them wearing a seatbelt, did save their life, but it did so much damage to them internally. It's amazing the damage that a seatbelt can do. But I'm not saying don't wear it, because you should, because it did. Because if they hadn't had that, they probably would have flew out the window and they would have died. So. Okay, let's see. So injuries are scored using what? Yep, and they're assessed based on the severity of the trauma. So if, we were to have like a multiple gunshot wounds, to multiple people, like all this crazy stuff that keeps going on in the world.
Like in Clovis.
Clovis, yeah. Thankfully, there were only a few people, but
402
two died, yeah. Yeah,
That was
it's
a
terrible.
year.
Mhm.
No, I had seen that under the terms, it said the Glasgow Coma Scale.
Yes,
There was nothing really in the
Yeah, I
book on
don't
that,
remember
so I looked online for that. 'Cause
what
only
question
people-
is it?
No, it says terms to know.
Oh,
Glasgow Coma
Review
Scale.
terms.
And all it had was just the RTS involved, the Glasgow Coma Scale, as well as other physiological factors. So I Googled it and it said a summation of scores for eye, verbal, and motor responses. The minimal score is a 3, which indicates deep coma or brain dead state. The maximum is a 15, which indicates a fully awake patient. The original maximum was 14, but the score has since been modified. Yeah, but that was underneath, it was terms to know for chapter 4.
I'm wondering if it was someplace
That was like a
else.
separate sheet, because I looked in the index, I looked in the glossary, and when I looked in the book, that was the only spot where I found that.
Yeah, because it's not even in the key terms.
Yeah, because I have it under. Know the following terms.
Yep.
Yeah, and in the CVP line, I found that it also has it as a central venous catheter.
Yeah. Let me see what. So it's the Glasgow Coma Scale is a component of the revised trauma score. And just like she was saying, that it assesses a patient's level of responsiveness to pain or other stimuli. Oh, there it is.
What about KG4? Would that be patients in a motor vehicle accident?
Trauma patients. Because when a patient is in a trauma, motor vehicle accident, any kind of a trauma, you don't know what's all been involved. So you have to, and you guys, I'm sure, have seen like things where that's one of the first things they do. Like if you see on TV, they're always going to stabilize the neck for the spine.
What about 44? I couldn't find that one. It's just
It's bariatric and geriatric. So those are the ones. And it kind of talks about those separately in the chapter. It's an integumentary system.
Skin.
Yes.
Oh, 55, is that military?
Yes.
What number?
55. The ones that are people that might come in with PTSD. And that's becoming more and more common. So when trauma patients come in, a lot of times a motorcycle accident or motor vehicle accident, the patient's going to have dirt and grass and anything else that they got from sliding. So like if it's orthopedics, or really any kind of surgical procedure, they're going to get scrub brushes and scrub out those areas on that patient to get rid of all that if possible. Really the main focus on trauma patients is to get to whatever is bleeding. And depending, they can have multiple injuries. They might have a broken leg, but if they have a spleen that was ruptured, that's going to be number one because they're going to bleed to death if they don't get that stopped. So that's what they're going to take care of first. So they are going to figure out what needs to be done most urgently, and those things will be done first.
The book said there might be times where there's simultaneous surgeries going on. Have you ever seen that?
I'm more like they fix this first and then the other
But they don't
two.
have two surgeons when doing.
They
Yeah.
a lot of times they're like in there just waiting to start their part. Yeah. But it could be like we got to get this fixed. So it's kind of hard though when they're if they're working on the abdomen for them to be moving the leg, it would be the general surgeon would be like, "Hey, be still. You almost made me cut the liver." Some things. So usually they're going to wait if possible. As far as moving patients, trauma patients, let the surgeon and anesthesia take care of that. You don't want to be responsible for displacing that neck, that spine, and they're going to be extremely careful with that patient. It does talk about having more than one Mayo stand, more than one back table. If it's a trauma patient and they have multiple things that are going to be fixed, there's probably going to be more than one surgical tech in there too. One to take care of orthopedics, setting that up, and one that's working with the general surgeon.
Does it always have more than like one surgical tech, or is it only special circumstances?
Usually special circumstances, yeah.
So if it's a general ordinary surgery or something, nothing out of the ordinary, run of the mill, there's just one surgical tech.
Mhm. Yeah, anymore, it used to be that it was the surgeon and us, the surgical tech, and that was it. So we were retracting, we were passing, we were doing everything with the surgeon. But now they have first assistants that are helping more and more. So there's almost always that other person in there. So we're retracting less and the first assist is doing more of that. we're actually being able to do our job, which is passing instruments.
Passing instruments.
Yeah, but it's actually kind of nice to do it just you and the surgeon, because when you're on call, a lot of times they're not going to call on somebody else to help. So it's just you and the surgeon. So it's like you might as well figure out how to do it without another person.
Because you're eventually gonna run into that.
You're going to run into it. Yep. Yeah. Or, you know, there could be like if there were several patients that came in because of trauma, they're not going to have enough staff to take care of, you know, having extra people in your room. So there's going to be a surgical tech and a doctor working in this one, and there's going to be another one working in another one, and, you know, whatever. So you just have to be able to, and usually it's the surgical tech and the surgeon who has their head on and that can focus on what needs to be done. The circulators and everybody else is running around the room like crazy people, like, oh my God, we got to get this done. You know, what are we going to do? But we just,
We're just kind of like.
we're focused on what needs to take place. Mhm. Yep. So do you guys have any more questions over the review? You ready to take this test? Can we go take it now?
No.
I'm not ready.
We can go take it now.
No, good.
We have 45 minutes. No? Christian, come on.
I was studying hard.
No. Then you guys are going to come in tomorrow and you're going to be chomping at the bit. Like, oh, come on, let's go.
Yes,
Come on,
yeah.
here's my coffee. Okay, and like if you guys think of questions when you guys are doing MindTap, when you're studying, if you think of something and you're like, I just don't know, we can open up a discussion board where you guys can submit questions and other people can, you know, because if you're having that question, probably somebody else in the classroom has it too. Yeah, a lot of times somebody else has that same question. And a lot of times you guys are just overthinking it and thinking, oh my gosh, I don't know, it's not in here. All right, well, you guys enjoy your evening. And we will have a test tomorrow. Daniel, did you have questions?
Enjoy or